Hollywood and media have done us a little bit of a disservice is to propagate the concept that the CDC and the federal government is in charge of health and public health, when in fact, constitutionally, it's a state service that each state is individually in charge of public health.
Hello and welcome to Informatics in the Round, the podcast that's designed to have every kitchen table in the country talking about informatics and the way they can understand it. I'm Kevin Johnson, a physician and informatics researcher at the University of Pennsylvania at KBJohnsonMD on Twitter. On tonight's episode, we had some amazing guests. Dr. Bryant Thomas Karras is the Chief Informatics Officer and Senior Epidemiologist at the State of Washington Department of Health. Using his background in internal medicine and biomedical engineering, and having worked with public health agencies at a local, state, and national level, Dr. Karras helps agencies utilize new technologies in their public health efforts. He's also been a faculty member at the University of Washington, where he shares his extensive experience with students, those lucky people, and now he's sharing his knowledge with us today. Welcome, Dr. Karras. We also have Dr. Jessie Tannenbaum, an internationally recognized biomedical informatics expert and associate professor at Duke University School of Medicine. She recently concluded a 5-year tenure as the Chief Data Officer for the North Carolina Department of Health and Human Services, where she spearheaded initiatives to enhance data-driven decision-making and improve public health outcomes. She is an advocate for precision medicine efforts, mental health, and women in STEM, and we are so excited to have her with us today. Finally, we were joined by a new guest, someone I'm a huge fan of. Lauren Malloy hopped on as my co-host for this episode. Lauren is the Administrative Coordinator for the Artificial Intelligence for Ambulatory Care Innovation Lab at the University of Pennsylvania, which investigates how technology can address healthcare challenges. Lauren had excellent insight into how public health issues manifest in our daily lives, and we were honored to have her as a guest star. So in this episode, we discuss exactly what public health is, how it varies on a state and national level, and how public health and informatics interact to create more efficient solutions to public health crises. Of course, given the name, public health touches each of our daily lives, and we talk about everything from the monitoring of communicable diseases like good old COVID-19 to the potential always having your medical history on you with the National Patient Identifier. I learned so much from our guests, as I always do, and I hope you do too. Well, with that, let's get into this episode. Okay, everybody, welcome to Informatics in the Round, the podcast that's designed to help all of our kitchen table colleagues know what we do in life and talk about all sorts of issues, occasionally about informatics. I've got 3 outstanding guests here today. Let me start with Lauren Malloy. Lauren, who are you?
I am the Administrative Coordinator for the AI for AI Lab at University of Pennsylvania.
Okay, I'll let you go with that. Today's topic is about public health informatics, and we've got really 2 of the people who are the most involved in the entire field of biomedical informatics here as guests today. So I'm going to start with Jessie. Who are you?
My name is Jessie Tannenbaum. I'm faculty at Duke. I've been faculty at Duke for many years, but I took a leave of absence in spring of 2019 to serve as Chief Data Officer for North Carolina's Department of Health and Human Services. So I was there for 9 months, and then COVID hit, and then everything went crazy. So trial by fire, learned a lot, meant to be on leave for 2 years, stayed for 5. I have just finished up that role, so I'll be going back to Duke in the fall, but have definitely learned a lot over those years.
So did you serve or were you served?
A little of both, I would say.
That was such a setup. Thanks. And then we're also really lucky to have Bryant Karras here. Bryant, also known as Dr. B. How are you and who are you?
Hey, thanks for having me. Honored to be on your podcast, Kevin. I'm the Chief Medical Informatics Officer, CMIO, for Washington State Department of Health. I've been serving the great state of Washington for almost 25 years now in
Wow.
various capacities. Three secretaries of health ago, or two ago, I was asked to serve in the CMIO capacity. I was the first faculty in public health informatics at the University of Washington at the time, and tried wearing two hats at once, and eventually became a full-time CMIO at the Department of Health. I still have an affiliate appointment at the University of Washington, but 4 days, 4 10s at the Department of Health, and then 110 at the university. Just don't tell HR that I work more than full-time.
And I promise none of them will listen to this podcast or watch you on camera. And for people who are listening, you have to know that when Brian says he's wearing two hats, he looks amazing in one. So I can only imagine what two looks like. So Lauren, your job is to be everybody else in the entire public who doesn't think about healthcare necessarily and asks all the hard questions. So you should understand everything these guys are talking about.
Okay.
And I thought it would be really important to have you here because I know you're not afraid to say what you're thinking.
That's right.
Thank you. Okay. So when I first heard that public health was starting to understand the importance of informatics, I was kind of shocked. So let's just start by educating people. What is public health and why is informatics important to public health? I think of public health as, obviously we can all use a simple example, which is COVID. And why would public health matter? And what is public health?
Public health with a capital P is the governmental side in our country at the state government and local government level that is protecting everybody's health interests. And that has a broad scope from infectious disease, as we all now are well aware of, but things as simple as water safety and food safety, environmental issues. So it goes beyond the classic clinical health. I think that COVID-19 really put us into a spotlight where epidemiology became a household word.
Yes.
Where it had never been before. And even my own mom called me up and said, "Oh, now I understand what you do," because it became so front and center.
She said, "You're the vaccine police."
Well, she was a little bit more sophisticated than that, but she called me up and asked me if she should be wearing a mask. And okay, Mom, you get it now.
Now, at what point during the pandemic was that? Because the answer changed over time.
Yeah. That was actually pretty early because, as you guys are well aware, Seattle and the state of Washington got hit early with the first detected disease in February and the first death at the very last day of February. We were in the spotlight in many ways, and people were concerned about us, and I was getting calls not just from my mom, but from people all over the country calling up and saying, "Hey, what can we do to help?"
So, Bryant, is it fair to say, and Jesse, is it fair to say that an adage of public health is that the needs of the many outweigh the needs of the few? Coining a phrase from Dr. Spock, of course.
Yeah.
I would say that's fair. I would say that is the agreement among public health people. And when we get into troubles is when people not familiar with the why around that strongly object. And I have my freedoms and I can do what I want.
I think that's always a big question is why is government allowed to be or so interested in being so involved in healthcare? Like they're government, like that's not really part of healthcare. But obviously when it comes to the funding part, they want government to be a part of it. But yeah, it's always like, well, you shouldn't be involved in healthcare. That's not, their business sort of thing.
Great question.
Yeah, it is. So what's important to understand is that it's not that the government is taking care of people. They're not providing clinical care. They are doing policy. They're implementing and enforcing policies that are going to keep people healthy. So you do sometimes have your local health departments, particularly for populations that may not be able to afford, may not have insurance and may not be able to afford healthcare. But overall, it's really about things like making people aware that they should be getting vaccines, that is a well-known thing that keeps people healthy. Making sure when you go in North Carolina, every restaurant you go to has a sort of sanitation score to show like how well they've done with that. And that's public health. Two things I didn't actually realize before I joined the department, testing well water to understand if that's healthy or not. So those are not things doctors are going to do. That's a government role there.
That's looking for cholera, right?
For cholera and, all those fun things. There's some really interesting issues there of kind of identification of metabolites in your wastewater and the privacy issues, but that's a different issue.
So Lauren, does that help?
It does. I think it'll.
Yeah.
And I think, Kevin, one thing that I think Hollywood and media have done us a little bit of a disservice is to propagate the concept that the CDC and the federal government is in charge of health and public health, when in fact, constitutionally, it's a state service that each state is individually in charge of public health. And CDC is there in an advisory, supportive, funding, oftentimes role to give guidance. But when a state is having an issue, it needs to invite CDC to come in and assist. CDC can't just march in, except in extreme circumstances.
Bryant, I'm so glad you brought that up, because this is one of my big questions. And this will, I think, feed into informatics, right? I believe it's still a fact that about 25% of the U.S. population lives within some number of miles of a state border, which means that their healthcare crosses state lines. I believe it's also the case that the world has become significantly more global, and therefore the days of a constitution where you were horse and buggying your way around, or even maybe a few cars occasionally, exactly those are gone. Isn't it weird to you that public health in 2024 would be considered sort of a state-organized, I hate to use this word, confederacy, which is actually kind of what it looks like, versus something that is more centrally mandated?
Let's say federated, Kevin, rather than confederated.
Okay, fine.
That's better.
Less charged of the term.
Well, we're in the world now, we're all about terms like structural racism and confederacy, and those are actually like supposed to be factually done. But let's just go with that. Isn't it weird that the states are federated as a state federated system rather than a centralized system?
It is a challenge, I will admit, but I think that what's wonderful is that we now in the last decade or so have the tools that enable us to operationalize that federation more effectively. Going back to the horse and buggy days, when a notifiable condition crossed a state line, it would be a Pony Express postcard that was carried from one state to the other to transfer the logging of that case count to a different state's tally book. And then they would report it up to the feds in terms of total numbers of de-identified cases. Nowadays, those transfers and rules-based systems can happen in milliseconds, so that we now to create an ecosystem where the states can work together seamlessly. We have organizations like the Council of State and Territorial Epidemiologists, CSTE, where each state is able to send a representative, a voting member, to the council, and the states themselves, as a federated unit, determine what are the conditions that we're going to report to CDC.
I see.
And then those rules, case definitions are, and you should be in the room sometime, Kevin, to watch the sausage making, because the arguments get pretty heated about how a case gets defined, and different doctors from different states have strong opinions, but they come to consensus, come to an agreed upon definition so that we're all counting the same things. And then we set those rules into a knowledge-based system that can operate so that a provider's system can send to the CSTE's centralized RCKMS, the Reportable Conditions Knowledge Database management system, and that management system can run through the algorithm to figure out, okay, this is reportable. What's the home address of the original patient so we know which state to report it to?
Got it.
Sorry, I just wanted to mention something that was sort of novel to me as I joined the public health group. Bryant just mentioned developing a case definition. That's what we informaticians call a phenotype. So we've spent a lot of time saying, what codes or what text or what labs or what meds or whatever defined a phenotype. Case definition is how epidemiologists talk about it in public health.
Got it. I didn't know that. I thought it was going to be something like what EIS workers would do for the CDC when there's an outbreak of E. coli O157H7. That's a case, but it sounds like it's bigger than that.
Yeah, it's probably not a perfect match, but typically when we talk about phenotypes, they're talking about case definitions.
And EIS officers, a perfect example. That's a resource that CDC hires those postdoctoral or post-MD fellows as EIS officers that can be detailed out to states. So they get embedded within a state, and they do, this is kind of a morbid, they hope that some interesting notifiable condition occurs during their time in office in that state. So they have something interesting to work on and write up, like an E. coli case. Following the case definition, they do those investigations, figure out if it is in fact a case, and then quantify it.
I see. Lauren, you have this look on your face like there's this question you're dying to ask.
No, I'm just thinking of like relating that. Like it's almost like when me and my sisters were like, 13 or 14. I'm like, okay, we're only going to tell mom and dad about these situations, and like if these factors happen, like if someone gets arrested, we'll tell mom and dad, but otherwise we're not. Like if someone's bleeding, we might tell mom and dad, but otherwise we're not. Like it kind of like they all get together and they're like, okay, this is the criteria where like we're going to tell mom and dad, about this case if this happens.
I think that's actually about how it works, isn't it, Jesse?
It sort of is. There's one other level, which is there's a way that mom and dad can get notified by someone other than you. So like if they get in jail, they'll probably get a phone call and you don't have to worry about whether you're going to tell or not.
That's fair.
Going back to the original question, Kevin, I totally agree. I wouldn't say it's weird. I would say it's inefficient that it is federated as opposed to, that it's all the different states running their public health. But there's also, on the plus side, there's sort of Secretary Cohen in North Carolina used to talk about public health at the speed of trust. And so there is some level of kind of this local feeling of, okay, I know these people. I interact with these people. I'm giving them my data. I'm coming forth when I might have a very stigmatizing, contagious disease and offering myself up to be tested and for that data to go somewhere. And I don't necessarily want it to be among the feds, government with a big G. Like my local healthcare workers are who I trust for this. So that's a plus to it as well.
That's a really good point.
That said, one of my pet peeves or favorite issues is a national health identifier, that we need one desperately. And the fact that legislation prevents even looking into it and doing research on it is a moral failing on our part. And I hope that changes over time. I know we've sort of started in the House to lose the registration prohibiting, and I'm hoping that goes somewhere in the not too distant future.
Well, we hopefully will talk about the 20-year plus odyssey of trying to get to a national public identifier. But let me just say one thing first, which is I would imagine that because of this federated model, language issues, colloquial issues do get in the way of reporting. Is that part of what's the reason for informatics being so important, or are there other things I should be thinking about, Jesse and Bryant, about why public health and informatics are the Reese's peanut butter cup of today?
Well, I'm going to go back in time, 20 years. Syndromic surveillance, I think, is a great example of how colloquial terms are important and how informatics can be the tool to normalize those terms across a federated ecosystem, so that when somebody in the Carolinas fell out, in the Pacific Northwest, we know that that means they fainted. And those terms used in chief complaints in emergency room departments have to map to the same thing in order for our national perspectives to work and give a view of what's happening all over the country. An epidemiologist who's practiced their whole life in Seattle is not going to understand terms used in the South to describe a fainting spell. So there has to be that localization, that expertise, that translation to understand, well, this means that, and do that mapping and bring it together into the right definition.
In other words, statements like, I don't know what you're talking about any more than I know Mary's. Oh, I forgot this colloquialism. Darn, I've been away too long. Wait a second. I don't know that any more than I know Adam's house cat. That's a classic,
Okay.
a classic
I've not
colloquialism.
heard that one.
Yeah, it's even further removed than not knowing anything from Adam.
Adam's house cat.
I want to point out there's an equity issue here. So informatics is super helpful, and I'm glad it's being recognized. But there's an equity perspective, not from the perspective we usually talk about in terms of race, ethnicity, et cetera, but rural-urban divide. That we all work at large academic medical centers, and we're kind of used to a certain level of sophistication there. And when you think about the small practices that are seeing people with communicable diseases and having to report that, they just don't necessarily have the electronic health record, certainly not some ECR, electronic case reporting, gets to what Bryant was describing. Not all the providers have that by any means. And so there's a lot of manual labor still going on.
So they're still using paper?
They're still using faxes.
Fax machines. Yeah.
Wow.
Absolutely. And that's if still using faxes. Side note, I learned something also. When I think communicable diseases, I always thought of them as communicable between people. So if I have interactions with someone, I can give them this disease. It's communicable, meaning you need to communicate it to the public health authority. Isn't that interesting? Yeah.
Is that what it really means?
Can you confirm this, Brian?
It might be a double entendre. It is. So a notifiable condition, I think, is another term that when I first started practicing in public health, really understood the nuanced difference between something that needs to be reported to local and state public health versus needs to be transmitted, de-identified as a case count to the CDC. And I think that nuance of what's notifiable versus reportable is something that's often lost on folks as they think about the ecosystem. And in informatics, in clinical medicine, we think about all the de-identified, personally identifiable information transmitting back and forth. But to take that and then figure out, what does a national picture need to know? The national picture probably doesn't need to know the individual name and home address of people with a particular condition, but they need to know the scope and scale of the problem.
They do, but one challenge there is if you are de-identifying it, and per the what we mentioned earlier, people live by the border. So if you're de-identifying it, and I live on the border with South Carolina, you've reported Jessie in North Carolina, and now she saw a provider in South Carolina. If you report that again, we don't know that it's the same person. Another reason why a national identifier, even if you then hashed it and didn't know who it was, would be very helpful, because then you could make sure you knew.
And that's where that ecosystem where the states are coordinating and sharing this information to figure out, okay, who is actually the owner of that case, so that it only gets reported once.
So I want to get into this, but I want to bring Lauren into this. Lauren, do I have permission to talk a little bit about your health issues for the next 7 months?
Yeah, of course.
Okay. Is there something that's going to change in your life in the next 7 months?
I will be having my second child in November.
Yay!
Congratulations, Mazel
Yes.
tov.
Yes. So my question is this: have you heard about measles?
Yes.
What have you heard?
That I need to get vaccinated against them.
Why would you have to get vaccinated again?
Not again, but just to make sure I'm vaccinated against them in general. I don't know that I got it. I couldn't tell you the last time I got vaccinated, but according to my health records, it must be at least recent because my OB was satisfied with the answer that she received. But
So what role do you think public health is playing in helping you to manage measles?
nothing other than my OB telling me I need to get vaccinated against it. Like, that's literally just my doctor, and I believe her. So here we are.
So public health experts, help her to understand the role you're playing in helping this country to manage measles.
Yeah. So the acronym in CDC that people often forget is that it's Centers for Disease Control and Prevention. That P in the name that doesn't get listed in the logo is what's critical here, in that, similar to the Council of State and Territorial Epidemiologists deciding what's reportable and notifiable, experts from around the country have decided what are the vaccines that will prevent disease and what are the recommendations, how often to have them, what to have, and inform that guidance, those guidelines, to your OBGYN and to the pediatricians so that they know what the vaccine schedule should be. And it evolves over time as we learn more about different vaccines, as we learn about different migrations or changes in the disease itself. It's not an exact one and done science, it's an evolving science. And you quite likely had a vaccine as a child, an MMR, measles, mumps, and rubella, which was a combined vaccine to protect you against a lot of different horrible diseases that you could get as a child. And what your OBGYN is going to do is make sure that you're still adequately protected from that. And then after your child's born, make sure that they are in line to get that vaccine, that protection for themselves.
On the back end, Public Health Stores has an immunization registry. And so within the state, again, this is state-based, there's a record of all the immunizations you or your children have. If you go between states, I'm pretty sure the IISs can communicate with each other if you're lucky.
They can now.
They can now. Progress.
Yeah, there's a new, relatively new, the last 10 years, an initiative called the IZ Gateway, the Immunization Registry Gateway, which allows state-to-state reconciliation of vaccine records. Because as we all know, in our country, we can freely move about the states. So, but your golden record of what happened when you were a child is back where you were when you were a child. So how do you get those data to flow? In today's day and age, we now have the infrastructure through our partners at the APHL, American Public Health Laboratory, Association of Public Health Laboratories, allows for this reconciliation between immunization information systems.
Okay, so question number 2 in the measles conversation. So Lauren, you live in New Jersey. Lauren, you work in Pennsylvania. How do you know whether you're exposed? I mean, how do we help you know whether you're in one or two states that have had examples of measles cases? Is there a way to figure that out?
I'm sure there is. I would say, I think during COVID, there was a website, whether or not it was legitimate or not, who knows, as to cases in each state. So I'm sure those exist for various different diseases, and I'm sure.
But per Jesse's point, isn't it possible that somebody like you could contract measles in Philadelphia, but actually have to report it in Jersey?
Yes.
So we need some way to reconcile that Lauren Malloy in one state is the same as Lauren Malloy in the other state. And I believe that's what Jesse's been talking about with this national patient identifier, right, Jesse?
Would be awesome. Yes, that would help considerably.
So that's obvious. We all have one. It's a social security number. What's the problem?
We're not allowed to use that. per a federal law.
There's no lawyers on this call right now, but if there were, they'd be
only
cringing.
behind me.
Yeah, exactly. They'd be cringing. The lawyers got very nervous anytime you mentioned social security number, and it is pretty restricted. When I started the job as chief data officer, someone said, if someone says you can't share data because of the law, ask them to see the law. And so in many cases, it's just how it's perceived. But I remember seeing the writing, and sure enough, it really is pretty restricted on how you can use the SSN in certain situations. So yeah, you're just not allowed to use it for a lot of these health purposes. People have concerns about privacy of like, if I've got an ID, then all my records are going to be out there. It actually could improve privacy considerably, because instead of having to send your name, your address, your whatever, you just send the ID, which if someone just saw a number, they wouldn't know who it was. Another thing is it can help prevent, actually Kevin Johnson, there's got to be many hundreds, if not thousands of Kevin Johnsons in Pennsylvania. And so it would be easy to imagine you accidentally getting access to someone else's record because they thought it was you. This actually improves that privacy and makes sure that you're not going to accidentally say someone else's record.
Agreed. My credit report would absolutely validate what you just said.
Okay, cash and credit. I was with Kevin Johnson's, yeah.
Depends on the day. So this is one of the many challenges that we have in our public health infrastructure. Jesse, what are some of the other ones, and what's making them still problems if we can recognize them?
The National Public Identifier is one key one. Another thing that's challenging, actually, as I think of that, is identifiers of providers. When we go for Medicaid to say, like, here are all the providers you can have, the complexity is insane because you've got providers, they've got their NPI, but then the offices that they practice at have an NPI. And then do you want to say it at the practice level? Do you want to talk about things at the provider level? Then there's also different addresses and locations. There's billing address and your service address and your mailing address, and they can all be different. So that also.
Oh, and providers, because was one, can practice at more than one location or moonlight at another location. So they get the same provider might come through different billing mechanisms depending on the day of the week or the hour of the day.
They also, from the Medicaid perspective, which is a little outside the scope of public health, but certainly related, they have an ontology of provider.
Whoa, that's a big word. That is a big word. What the heck is that thing?
So good question. Ontology, I like to think for informatics people, they're going to kind of get it. It's basically a dictionary of words on steroids. It not only defines the words, but it defines the relationships between them. Let's put it that way. And in this case, if you're talking about specialties, you can have, it's sort of a hierarchical thing. So you can have a cancer specialist, a breast cancer specialist is a subform of cancer specialist, a pediatric oncologist is a cancer specialist, but also a pediatrician. So it can have multiple parents. So it gets a little complex. On the epidemiology side, they know the word ontology, but what they do is say, this doctor has that ontology associated with them. Like, instead of a term in the ontology, they'll say, what is their ontology? It made me cringe for a very long time. I finally got a little bit inured to it. But that gets complicated because if you're one specialty, you can't bill for something else that's not done by that specialty or that sort of thing. So there's a whole world where informatics people could help considerably. Not that these standards don't exist, but connecting the standards and the know-how with the people who are trying to build the systems to enable this kind of thing.
So in the world of public health, if there were no ontologies, answer this question. Without an ontology, we could not do blank. What would it be?
Without an ontology, we could not find a provider for our specific need. We could not code new cases. So when COVID came out, there wasn't like a term for it. And if you have multiple ones, then you might say long COVID or this, and you couldn't kind of selectively say, just show me all the COVID things. Don't make me search for every new term.
Yeah, the rolling up to the common denominator so that each of those individually accurately constrained terms can get rolled up to a term that public or leadership or legislators can understand.
So, for example, if I said, tell me about the environmental toxicology work that's being done in the public health space, Flint, Michigan, that's one piece of the ontology. And if I said, tell me about the infectious diseases that are being managed, that's a second piece of the ontology. And if I said, tell me about the co-occurrence of AIDS and syphilis, or HIV and syphilis, for example, that requires an ontology because each of those themselves have a set of subdiagnoses. Is that basically right?
Yeah, although you were saying the ontology, Kevin, as if there's an ontology in the world. And sadly, there's not. There's so many with overlapping content.
Yeah.
Yes.
And in fact, I've gotten invited into, on the environmental health side, which you mentioned, lead in particular. It's a challenge because in that world, the patient isn't necessarily the person. The patient might be the address or the water system, which is a very different set of specialization than the healthcare industry, which is focused on the person. So the standards and even the way they encode things, they're following their own set of rules and norms. And to get those two worlds to talk collides in the public health space.
Yes.
And needs an informatician that can understand both spaces so that you can keep people talking to each other.
That's amazing. So is it generally now that it's the case that most states are begging to have Jessies and Bryants, or are they generally thinking, we've got this, we don't need your informatics people?
I would say we're seeing more of it. We're seeing the recognition of the importance of it. We're not seeing the funding for it. The creation of a chief data position, chief data officer, or Brian, it occurred to me, North Carolina doesn't have a CMIO. And I'm curious, do you know how many counterpart people you have across the country?
So we just, the folks in my position, although, and Jesse, you should have been there had you not stepped down. We all just met in Kentucky, in Lexington, and we went around the room, and the diversity of titles is amazing.
Do we need an ontology for titles?
Probably.
No two states seem to define the role with the same name. However, the work that we all do is completely analogous. So we try to come up with a definition that is inclusive and everyone can feel like they belong in this group. But it is a tremendous challenge. Some states, like mine, have embraced it early on. Many states are still resistant to it, and as you said, like, well, we've got a CIO, someone who's in charge of IT. So why do we need this? And we've got an epidemiologist in charge of everything. So not recognizing the need for that individual that can serve to translate and has expertise in relating to the outside world, outside of the agency.
I've actually got a summer student working on a project where we tried to track down what are the analogous kind of health and human services agencies across the country. And then we're contacting them to say, do you have a chief data officer? Do you have an office of informatics and analysis? What's the closest you have? What's the org? How's it funded? How big is it? That kind of thing. So maybe after the findings from that, we can develop an ontology of this and see what it all looks like.
If you asked that question, Kevin, 20 years ago, the answer would have been most states' health departments don't even know what the word informatics means. Now we've reached a level of maturity that secretaries of health or commissioners of health can use the word informatics correctly in a sentence. They know they need that skill set. And now it's just a matter of organizational acceptance. What's a position that they can drop in to meet this need? And are there enough experts in the workforce to fill those roles? And we're kind of in a situation now where we desperately need more informaticians to be trained through our academic partners, through fellowships where people can come into the public space and utilize their informatics skills for public good. It's a tremendous need in our country.
So is that a need that relates to knowledge or hands-on or both?
It's a little of both, I would say.
Yeah.
It's a little of both, and there's a shortcoming in just awareness, I think. If you look at just the makeup of AMIA, you've got all these informaticians. Public health is a teeny tiny part of that community. And obviously there's CSTE and other sort of epidemiologically oriented ones, but informatics and data science, I think they would argue that they are data scientists. And certainly the sort of statistical analysis happens. But one of the best sort of breakdowns I've thought of the sort of difference in culture is that epidemiology, they use data, but they have a question and they want to get the answer to that. And they kind of do that the one time. Versus informatics, where we say, like, we have a question and we're going to have that question over and over again. Or we might have similar questions, or we might have questions we can't even anticipate now. How can we build the systems that are going to enable us to keep asking that question and related ones and make it efficient?
That's a great segue into this question. So during COVID, many of us started to rely on the Bloomberg dashboard. So you'll know this is the one that came out of Hopkins that everybody was using to say, at the state level, this is how much COVID we're seeing, this is how many hospitalizations, et cetera. Tons and tons of data. Would you say that was primarily epidemiologic work or informatics work to pull that off?
I think it started out as epidemiologic work and totally unscalable. And then at least in North Carolina, and then over time, it turned into informatics work.
Yeah. And Kevin, that particular dashboard gives me a little bit of PTSD in that
probably all of us.
They would screen scrape our public-facing dashboard to pull the data down and populate their dashboard. And when our numbers would change, because those dashboards are dynamic and retrospective data would come in for past days and we would update the case counts and the curves would change slightly. But the way that at the origin story, that dashboard at Johns Hopkins couldn't take into account changes in things that had been scraped earlier. So they couldn't go back and say, okay, well, let's adjust for that because they were scraping it day by day. That's not how an informatician would design the system. That's how a pragmatist would build it with the tools that they had in hand. And I think what we need to future-proof this is let informaticians figure out what are the APIs, what are the mechanisms that we need to institutionalize or systematize so that the next time this comes around, we've got a much better set of tools.
So Lauren, do you know what I'm talking about? Did you ever see the dashboard? Yeah. Did you ever find it useful?
Not really useful. Like, I mean, I would just go and look just to look, but not that I ever really used it for any sort of, informational purposes per se.
A lot of people used it who were traveling. Like they wanted to know how much COVID was there at that time.
Where are the hotspots?
Yep. And then Google used it as one of the ways that they could actually overlay some of the data about the transmission at particular times with the population. So you could actually zoom into a zip code and get a general sense of the prevalence of the disease. And I know a lot of people who would say things like, well, we want to go away. We're tired of living in our little bubble. So we went looking on the map for places that didn't have as much COVID. And I think in general, that was a good use. To me, Bryant, what you're talking about and what Jesse's saying are the fuel that we need to say we should have learned something from COVID that would bring together both what one can do with duct tape and what one should do with informatics. Do you think we've learned that? Are we ready for example, the bird flu?
Yeah, well, I think the data modernization initiative which is a CDC. It actually predates COVID. The Data Modernization Initiative started almost 10 years ago to try and modernize public health systems. And then it got a huge infusion, tenfold infusion of capital.
Wow.
When it was made completely apparent that we underestimated the lift that's needed to modernize public health systems. So across the country, states and locals and the CDC themselves, actually the initiative started just within the walls of CDC to recognize that the centers, plural, because people don't realize that it's multiple centers at CDC, each had their own technology, their own siloed systems. And the Data Modernization Initiative in its origin story was just to try to modernize CDC to think of itself as an enterprise instead of these individual dependent systems. I think we've got a long way to go still. We're several years into these modernization stories, and the investments are starting to pay off. We just got to hope that the investments last long enough to pay out the dividends.
Yeah, I totally agree with that. I'm a big fan of the Data Modernization Initiative. The one issue I have with it, and at the beginning of our conversation today, when you asked what is public health, I had to remember the hat to wear because, as I mentioned, I was CDO for Health and Human Services, which is much broader than public health. My issue with the Data Modernization Initiative is that it is very public health focused and it feels to me like it's got a little bit of blinders on. And when we talk about, you don't care that it's your public health department that deals with your immunization, but your Medicaid that deals with your Medicaid and your mental health that deals with your mental health. You're a person and you have all these needs. And so in North Carolina, we talk about whole person health. And I would love to see the Data Modernization Initiative think a little more along those lines of whole person health. It's not just about your immunizations and your communicable diseases. We also need to understand what social services is this person getting. Now, Big Brother, privacy, there'd be a lot of governance needed around this, but for similar reasons to why we need a national patient identifier or medical identifier, we need to really think about all of these different experiences together, in my opinion.
Yeah, so in the state of Washington, again, predating COVID, we formed what we call the HHS Coalition, where all of the different health-related agencies within the state government banded together to make sure that we were co-investing in resources. And one of the amazing things that's come out of it, which will give you some hope, Jesse, is that the DSHS, our behavioral and mental health, our state Medicaid, which is healthcare authority, and the Department of Health all said, let's all co-invest in the same master person index so that when we're talking about a person, we have the same identifier across our different siloed agencies. So that co-investment in recognizing that people don't understand the nuanced differences between our different state branches. They just want good care.
Right, exactly.
And so we're trying to make that a reality by co-investing in tools. And I think you're talking about wanting that at the federal level, which conceptually I agree to, but I think operationally could be a challenge. And even things like, privacy preserving record linkage, PPRL, has some flaws or has some risks that I think we need informatics to dig in and help us assess what is the best strategy moving forward.
Well, that's really great.
It's a shame to have to solve it in 50 different states plus however many territories.
Oh, I think one of the things that I'm reminded of is that it's not just states and territories; it's also the freely associated states. Micronesia is part of our ecosystem, and we can't leave people behind.
I have to tell you, I had never heard of that term before in my life, ever.
PRL or the association?
Freely associated. Is that Guam?
Guam's so the Federated States of Micronesia and Guam American Samoa, all of these territories and freely associated states fall under a protectorate status that we can't leave behind. And ASTO, the Association of State and Territorial Health Officers, another a group that I think is doing amazing work in the data modernization space. It's actually the each state and territory and freely associated states have one member health officer. They're official. So it's a member organization. Now, the people who actually participate in ASTO are much more than the figurehead of each state, but which is why organization is absolutely comes to mind. But it's because of COVID, I think, in many ways, has put a spotlight on the progress that states have made has not necessarily occurred in the territories. And even things like broadband that we now take for granted haven't necessarily made their way out into the frontiers.
Yeah. Lauren, any questions?
No, I'm just thinking about modernization of data, and I remember the first time I realized that each entity, each hospital, each doctor's office even didn't use the same system. I always just thought if I go to the hospital, they should have my records from my doctor's office. That should happen. And I realized that, and I was like, what do you mean you don't have, not that I don't know, but what if I was in a position where I couldn't tell you, my history or whatever? You should just be able to have that. And they were like, well, yeah, but then you could just go to any doctor or any hospital and we wouldn't have not control over you, but just
oh, I think that might be it.
Yeah.
You might not have said it, but
yeah, we wouldn't be able to, keep you because you could just go anywhere and they would have your information. I'm like, but I could just take my information and go anywhere. But that's more work on my part, not on their part, I guess. But
well, that's like when we were in the middle of the pandemic, there were people who were getting their vaccine at, pick your favorite mobile van. And then they would go back to work and people would say, well, we don't have any record of you having received the second. Oh, no, I got it at this place. And there was zero
Kevin, you're
opportunity.
triggering me. Between that story and the Johns Hopkins dashboard, I really should have braced myself for the triggering moments in this.
Yeah. So, and you're feeding right into one of my pet projects, which is the VCI, the verifiable clinical information, or
show that card again. There it is.
So
Lauren, tell Lauren what that does.
So, in Lauren, I think you're in New Jersey, Lauren. I believe New Jersey had a mechanism where the state health department could issue you a QR code that would prove that you received vaccines. This is my actual card that has. Actually, this is a demo card.
Yeah.
This is my actual fake card.
My actual demo card.
Yeah.
I could pull mine out of my wallet if I wanted to broadcast my actual birthday to the whole world. But
no, it's okay. We can figure it out from your hair color.
It allowed people to document in a non-forgeable way their vaccine status. And now what I'm hoping we can do collectively as a country is take the lesson learned from that and give people a tool, a QR code, so that they can get access to their health records whenever or wherever they travel, even outside of the US. The technology is called International Patient Summary, IPS, and Canada just announced within the next 15 days, they're going to go live in the first province with issuing this technology so that people can have access to these records, a mini medical record version that has your vaccines, of course, your problem list, all the meds you're on, your allergies.
Wow.
And I think that that's going to be a game changer, Lauren, for situations like you're saying where it's too much work for you to gather up your records to take with you from provider to provider. If only they could just issue you on your iPhone or your Android or a physical card a cryptographically unique QR code that you could take from place to place, so that people, without question, without having to like figure out which Lauren Malloy they need to request the records for, you're actually handing them something that says, this Lauren Malloy, and here are the records that I've authorized to be shared.
And I have to just say, that, Brian, thank you so much for that, because I remember when Hillary Clinton and Bill Clinton were working hard on a smart card that was going to be our identifier and our access to our record that would be on the card itself. That whenever I had conversations, I always said to people, so what would happen if you lost your card? Their answer would be, oh, well, there'd be a backup someplace and you could download another card. And then I would say, well, how do you read the card? Oh, we'd have to make sure we deployed a reading infrastructure. And for those of us who know about technology, those two are essentially almost non-starters. So now what happens? We've discovered the QR code. Everybody has a reader. And we've recognized there's no reason to use that card as a physical copy of anything that can't be that is otherwise private. You have a way of using the card to get to a permanent backup copy of everything. So it's a much more intelligent architecture. And Bryant, I really appreciate you bringing that up, because I think that one could scale. It basically, you could print those out anytime you wanted to and make copies of it.
And why do I need the card as opposed to just having the QR code on my phone? Because I'll lose the card, but I won't lose my phone.
Absolutely. The 90% of us are going to carry it on their phone, but we want to be able to not leave people behind and have a way to issue cards to people who can't afford a smartphone, and as a backup. Like, how many times have you been on a plane that, the chargers weren't working and you land and your phone is dead? You still want to be able to prove your vaccine status if you're going into a country that requires yellow fever vaccine. But I'm going to show one more card here, Kevin.
Okay.
This is somebody's actual record who's given me permission to share, and I'll let you scan it. Right, you said you have a reader.
I do.
Scan it right on the screen. Tell me if it works.
It's not in focus. Can't do it. But everybody else will be able to, because they'll be able to pinch you out and make it bigger.
Better
Yes.
version. Anyway,
so here, I'll pretend. Wow, that's amazing.
Spoiler alert, Kevin. This is ePatient Dave's card.
Wow. Who the heck is ePatient Dave?
Okay, come on.
Lauren, remember Lauren?
Okay, for Lauren's benefit, ePatient Dave is a patient advocate who's been working, I believe he lives in Vermont. And he gets a lot of his care down at Mass General in Massachusetts. And he's been a staunch advocate for the difficulty that patients have in carrying their records around and in the interoperability not delivering on the promise. And he's going back many, many years, has been active in AMIA, trying to push our envelope on interoperability. And we're really excited to be able to provide him with these kinds of tools that enable the digitization. And because of now the 21st Century Cures Act, he has the right to extract his own data from electronic health record systems. It's a bill that was signed by Obama, put into law, that allows him to, without expense, to pull his information down electronically so he can carry it from provider to provider.
And not just ePatient Dave, we should say. The Cures Act.
That only he gets this benefit. Yeah.
No, but I'm glad you mentioned it, Brian, because I was going to say, Lauren, to your point about seriously, everyone doesn't have it. The Cures Act did have rules about what they call information blocking and saying, you can't do that. You can't be like, our data is our data and we're not going to give it to your other providers. So over time, they keep kind of changing the dates of what needs to be done when, but over time, we're seeing some improvement there.
And it's both mentioning that the Cures Act was a bipartisan bill.
And I'd almost like it to extend to immediate family, because as someone who lost her mother pretty early in life, even now my OB will say, "Oh, did your mom have preeclampsia?" I'm like, I don't know. I didn't think to ask her that at 18. So I'd almost like it obviously you deal with privacy issues there and ensuring that is in fact your immediate family and not someone else who just has the same last name. But there's also that where people who are unable to disclose their, health history, that there's access to that to their immediate family members who might need it.
Yeah, Lauren, that's an amazingly insightful question in how our healthcare system is really powered by proxies or powered by folks who are taking care of their dependents, whether in your case, soon to be a child dependent, that you obviously would want to be able to have access to that information. And in the demonstration for this card that we created, we've allowed that same QR code to have not just your information, but your dependent's information as well in an ontology of different sub-participants within that record, so that you could keep all of those vaccine records for all of the kids that you may have in one place and not have to carry around a whole bunch of different cards. The adult dependence is a little bit more complicated because your mom and dad are going to need to give you permission to get access to those records. It's not an assumption that just because you're related, you should get full access to their medical records. So a lot of complexity to figure out.
Being stored out there.
Well, guys, this has been incredibly informative. As always, every so often, I have to play the I don't know enough about this role so that we can make sure that the audience understands it. But I can genuinely say, I don't know enough about this. So I got to learn a lot today. This is really, really, really great. And I have to tell everybody, these are two very much in-demand people. And it has taken us forever to get them scheduled just because their schedules are insane. They make me look like I'm perpetually on vacation. And Lauren, that's like, oh my God.
We literally had to do it like the day before a holiday to get them. That's how.
So, I've gotten better. I suspect Bryant, yeah.
Yeah, no, I spent 48 hours in my home last month. It's been a crazy whirlwind of different official capacities.
That's before the highly pathogenic avian influenza has arrived.
Kevin, do not foreshadow. But on that note, don't drink any raw milk. That's all I can say.
Yes. Yeah. So hopefully we'll have a chance, for lots of reasons, to revisit this conversation as this summer goes through. I mean, just to be fully transparent, California is now getting into their migrant farm worker season. I frankly fully expect that we're going to have more conversations about pathogens that might be a concern from what I'm hearing in other countries. And it would be fun to sort of talk to you guys about what have we learned from COVID that we can use to think about the next pandemic. So thank you so much. Bryant, one last thing. I see an instrument behind you. Do you have any music that we can add to the podcast and share with people?
Oh, definitely. That's my passion.
When do you have time for a passion?
Okay, that's going to be a quotable moment.
Thank you, Kevin. This was fun. It's a pleasure and an honor to have been part of this.
It's really been a pleasure to get you guys both here. Lauren, thank you so much for jumping in and helping to really kind of inform and make accessible this conversation. So this was wonderful.
Well, Thank you for having us, and I'm happy to come back anytime.
Done. Happy 4th of July.
You too.
Okay.
Take care.
Well, that was a great episode. I was really excited about the ways in which they covered so much of the material. And I have to say, there's nothing better for me than really good dialogue where I get to be quiet and listen. And Lauren did a fantastic job of asking questions for our two main guests to answer. Anyway, thanks for listening to this episode. To hear about new releases, find us on social media at InfoInTheRND on Twitter, Instagram, Threads, and TikTok. And if you have any questions or ideas for topics you'd like to hear us talk about for new episodes, please message us on any of these platforms or email us at informaticsintheround informaticsintheround@gmail.com. That's all one word, informaticsintheround@gmail.com. See you later.
All right, for those of you who've been drinking tonight, I hope this song brings you some solace tomorrow. I'd had a bad night. I mean, not so bad, I thought I was king of the world. And I drank till daylight. I mean, I never stopped once until my hands finally fell. And I fought my daytime self with a mighty dose of, hey, look at nighttime me. And I never do win that battle, but I fight it over and over and over, it seems. And I saw an old man smiling on a park bench feeding the pigeons. My head was spinning, and as my young body ached, I wished for an old man's vision. And I watched the way he moved, slow, serene, and lucky to be alive. Thought to myself, I'm never gonna make it that far with too many more nights like last night. And I'd rather be 75 and sunny than acting like I'm 17 and freezing again. I'd rather be up early in the morning than up late at night again, erasing memories of where I've been. Or to be through at 52 someday, stone-faced and bleary-eyed. You better believe I'm living for the moment, but my moment's growing bigger by and by. And I got a best friend. She don't drink or smoke like I've been known to. She's got religion. She's a one-woman dynamo and lights up every room she goes to. She says the light that's there won't go nowhere, no way. She don't spend every second smiling, but she's learning something exciting every day. She'd rather be 75 and sunny than 29 with a chance of showers all the time. She'd rather be old as dirt than new as any $9 bottle of wine. Or to be thought at 35, Mama Stone with her back to the wind. You better believe she's living for the moment, but her moment is the whole damn thing. And I see these spin kids, double wide-eyed rolling and rolling and tumbling. They're roaming in inches, taking a high dive approach and screaming towards the wall. Their hearts race a million miles as they buy another smile from a jar. Their bodies are screaming for the water, and you know, I just hope they can make it that far. I hope they're 75 and sunny, not 29 with a chance of flurries all the time. I hope we're all old as dirt, not new as every $25 ride that we try. Or to be thought at 35, Mama Stone with our backs to the wind. You better believe I'm living for the moment, but my moment, son's the whole damn thing. And I say I'd rather be 75, oh how nice, how easy for me to say. I've never broken a bone in my life, let alone had my heart or a hip replaced. And I keep this furious pace, and I still feel so good and strong. And I do get tempted for a taste, just a taste, to keep me going, 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 going. But I got a notion but everything I learn been coming around. And my devotion to the new thing, and the next thing, and the hip thing is slowing down. And I got a light in here, won't go nowhere, no way. And I don't spend every second smiling, and I ain't trying, but I'm excited for every day. 'Cause I'd rather be 75 and sunny than 29 with a chance of showers all the time. I'd rather be old and in the way than this year's new kid running for my life. Or to be through at 52 someday, stone-faced and bleary-eyed. You better believe I'm living for the moment, but my moment. Better believe I'm living for the moment, but these moments. You better believe I'm living for the moment, but my moment's growing bigger by and by. By and by. By and by.